Do we dare to change the rules? We, of course, will start by expert of experience who will tell more about the youth panel. And please welcome Paul Gillison and Raf Amaisia.
Thank you very much. I will be sharing my screen and hoping it all goes to plan. Yes, if everything goes correct, you should be seeing my screen now. So welcome, my name is Paul Gelissen, and together with my colleague Inge Gerrits, I organized the EFCAP Youth Exchange. And today I will be telling you a little bit about what this exchange is, a teaser of what we've been able to gather so far, and then afterwards give the floor to Raf, who is also one of the participants. Now I need to There we go. Yeah. Okay. So 2 years ago, my colleague Inge, she gave a presentation at the previous EFCAP conference, which was named "There is no magic in Harry Potter without Harry Potter: Improving the Quality of Care Together with Youngsters." And as you might imagine from the title, this covered the topic of youth participation and how we often tend to think for instead of with people, the people who our work is actually meant for. From this presentation, a call emerged to start giving the right example within EFCAP itself by organizing a program in which the voices of young experts by experience can both be heard, but also integrated in all of our professional work. This program is the EFCAP Youth Exchange, in which we will gather young experienced experts with whom we will together identify bottlenecks in the current system and come up with solutions from their perspective. Moreover, during this next year's EFCAP conference, we look forward to connecting these young people with your own work as well in an attempt to move from project production to co-production. So far, we have had one preliminary meeting with participants from Finland and the UK, of which I will share some of the most notable outcomes with you right now. So yeah, the first bottleneck that we identified, we dubbed, for the lack of a better term, person-centered care in a care-segregated system world. This bottleneck covers all different systems involved in the care of young people in the forensic mental health care, and how each of their individual efforts do often not amount to a sum that is greater than its parts. One example of this we heard involves the ages at which you're still considered a young person who falls under the youth care system and can make use of youth services. So, for example, at which age are you still an adult? Are you already an adult for the child welfare system, for the mental health care, education, or the law? And especially, what happens when those ages are different across those services that are charged with taking care of you? These types of situations are not productive for the recovery and reintegration of the young people, and are a good example of where the system prevails over what is in the interest of the person that the system is meant for. One example we heard from Finland is the situation where youngsters have to move hundreds of kilometers to a new foster home because within the foster system, it was decided that it is in the best interest for that youngsters. But at the same time, this has many consequences on other levels as well, such as that person will have to change care systems. They will have to go to a new school in which the educational curriculum that they had so far may not be aligned with what they had before that, and they may have trouble connecting the two together. And they can also lose many connections by being far away from the place they have been and from their family and friends. So one of the first steps in coming to a solution to this problem is identifying in which ways the separate systems do not mesh together well in aiding the young people's recovery. And to do this, the experiences of those young people themselves are vital. This, however, brings us to our second bottleneck. This is the meaningful and impactful youth participation. The second bottleneck can be considered in both an individual level, being informed and having a say in your own care, and also on a collective level, the degree to which the voices of young people are heard in the way services are that are meant for them are shaped and organized. Then there's also this distinction between participation for the sake of it and an actual impactful and meaningful participation. From the exchange, we have learned two interesting words from the Finnish participants that illustrate this distinction quite nicely. I hope I can pronounce these words correctly. So they are osalituminen and osallisuus. Obviously, I'm not Finnish myself, but we were told that the meaning of the first word is participation in general, and the meaning of the second word also means participation, but it also has included within it senses like belonging, involvement, inclusion, and empowerment. And the fact that these two different words for participation exist shows that not all forms of participation are equal. Rather, we would argue that these elements that are only included within the second words, belonging, involvement, inclusion, and empowerment, are actually requirements to make participation meaningful and impactful. So things we can think about when we speak of meaningful and impactful youth participation are shared decision making, having a meaningful voice in your own care and in care in general, and moving from production to co-production. So one last thing I wanted to share with you today is a best practice that we heard also from our Finnish participants, which is all about meaningful and impactful participation. This is called a peer review, and in these peer reviews, young people aged between 18 and 29 go together with support workers to residential settings like children's homes, for example. And these young people who do this are experienced experts themselves. They visit the visits they go on are agreed on beforehand with the NGO that is executing these peer reviews and the service provider. And after introducing themselves in the home and the purpose of their visits to the staff and the children, the young people with care experiences interview all the kids that want to participate. And the interview consists of some 100 questions, which have been developed in co-production with the young people and official inspectors. After the interviews, the young people and support worker leave and make a summary report of their findings. In the reports, they highlight the things that are going well and the things that need to be further developed to meet the children's needs and hopes. Then they go on to present the findings for the staff and the children and discuss how they can together make sure that the things that need to be better in the eyes of the children can actually happen. The summary report also is given to the children's social workers and to the local authorities who do the legal inspections of the residential care settings. 3 to 6 months after the discussion based on the summary, there's a follow-up to see what happened since then. So there's also a checkup. These peer reviews are a new model that is aimed at increasing child participation in residential care settings and to evaluate and improve the quality of services and care together. We hope that you take some inspiration from these bottlenecks, but also, of course, of this best practice I just presented to you. And of course, we also hope to be able to share many more insights with you in next year's conference. So that's for now about what we have done so far. And I will now give the floor to Raf, who will share some more inspirational insights from the UK. And we will start by watching an introductory video from him.
I'd first heard about mental health when I was getting in trouble at school and getting kicked out of school. A lot of bad things that used to happen in the area where it just becomes normal. A lot of friends dying. You never really identify yourself as a gang at the beginning. It's just a group of friends having a laugh. Substance abuse, smoking a lot of weed led me to committing an offence on a friend I became paranoid of, which resulted in me ended up on a medium secure mental health ward. Recovery was very difficult. There's not a lot of support out there after you're discharged. You know, there's not a lot of people to turn to. You got a conviction, you've got a diagnosis of a mental health problem, and there's a lot of stigma and discrimination which create barriers to you getting better or to you reintegrating back into society. When I was in hospital, I used to complain a lot about various things relating from restrictive practices to short staffing levels. I actually ended up being friends with an inspector from the Care Quality Commission. She suggested that I become an expert by experience, and upon discharge, that's exactly what I done. Coming across Signet Healthcare was really interesting because I saw a lot of positive things happening within their services. They kind of approached me to become an expert by experience lead for them, and my role is to ensure that service users have a voice at every level of the organization, and I work alongside them to ensure the feedback is actually actioned and something is done with it to improve the service. Being able to sit down with a service user and tell them I've been through what they've been through, and I've been through mental health services from a place where I understand where they're coming from, and it's almost an instant moment. You can see the service user's shoulders start to relax. I definitely feel like I have meaning in my life now. Seeing the same faces throughout my childhood in young offenders institutions, mental health hospitals, put a fire in my belly to just want to change the status quo. Having people believe in you and giving you an opportunity really makes you want to not only not let them down, but not let yourself down as well. I've learned so much through the organization. There's just so much room to develop, and I feel Signet has really been the leaders in demonstrating that actually we can involve people, even if they might have a troubled past or they might have mental health issues.
Raf is like a breath of fresh air. He's brought a whole new lens into how we work with our service users and our patients, how we can learn from them much more effectively than we have ever before.
If you're considering to come and work at Signet Healthcare, you're definitely making the right decision. It's a no-brainer. I think that you're not coming into this sector because you want to become a billionaire or you're doing it for the money. I think if you want to come into this sector, it's because you care, you're passionate, and you want to see people get better. You want to help people. And at Signet Healthcare, you're able to see people's recovery from admission all the way through to discharge, and potentially to come back and work alongside you as an equal colleague and staff member.
Hello. Shall I crack on, Paul?
Yeah, go ahead.
Thank you. Hello, guys. I'm Raf. I'm the Group Expert by Experience Lead for Signet Healthcare. As kind of outlined in the video, what I was hoping to do was just briefly touch upon some of the co-production work that we're doing here, and what I kind of oversee within the organization. And one of the primary things that we kind of do here in terms of co-production structures is something called the People's Council. And the People's Council, in essence, is what you kind of expect to see in any mental health service in the form of kind of like a service user forum or a meeting. The issue is with those, in my experience, is that often the information isn't relayed around the service, and in most cases, often doesn't leave the service. So, for example, in a large organization or your equivalents of NHS trust, just bearing in mind we've got quite a few international participants today. A lot of the time there'll be a cluster of hospitals under an organization, and more often than not, the service user voice hardly leaves a ward, let alone the hospital in its entirety. So what we've actually done here, we've got over 140 units around the UK, in England, Scotland, and Wales. And what we've actually done is incorporate the People's Council, so the service user meetings, at the heart of our corporate governance structure. So every decision within the organization has service user and resident input, including experts by experience and family carers. And what that does is, in essence, give service users and patients a kind of voice from every level of the organization, from ward to board. And how that kind of pans out on a local level, so within a hospital, the People's Council meetings kind of involve stakeholders. It's mandatory for management to attend, and family carers also attend, including kind of the regulators for that specific hospital. And that can be anything from, you know, what you'd normally expect in terms of activities and menus, and you've got a chef that kind of comes along and they co-produce menus together, but more about local protocol and how kind of finances are managed and stuff like that. The more fine-tuning stuff we really like to kind of get our service users involved in. And then again, on a regional and strategic level, so on a kind of board level, that's also replicated, but through policy, through co-producing policies, through co-producing different initiatives across the group, and ensuring that the service user voice is a fundamental part of every decision that's made from head office. And that's really in kind of a nutshell. Some kind of examples that I could give you is, for instance, one of the big issues that we've had during COVID, and well, some would kind of argue before COVID actually, is kind of nursing. I think it's kind of more of an international issue. So I know a lot of you guys may be able to empathize in your own kind of countries, but obviously nursing staff is a big issue. There's a big shortage nationally and perhaps internationally as well. And one of the issues that we've had historically within some of our eating disorder services is around how, you know, kind of toilet, bathroom access is facilitated, because more often than not, people kind of need to be observed in those situations. And if doors are locked, or, you know, bathroom doors or toilet doors are locked, for example, it can create a situation where when I first come to kind of working within the sector, not at this organization, but when I actually visited one of my first eating disorder services, I'd kind of come across some of the service users who were telling me, you know, they had to protest to use the bathroom, or in some cases actually have to like kind of lie down on the floor in front of the office just so a staff member would have would open the bathroom door for them. And I felt like this was just such a degrading and you know, humiliating display, which is like it's a human rights matter more to anything. And that was actually one of the first places that we established the People's Council, which is not only in our organization now, but now something that's been replicated throughout the sector within the UK and also within America as well. But I always go back to this because it's kind of one of the first policies that we were actually able to change from the People's Council. And we're kind of asking some of the service users what could be done to actually ensure that this doesn't happen anymore. And we kind of determined that at the beginning of each shift, a fire marshal is kind of chosen amongst the staff groups. And in the same way that a fire marshal is chosen for that specific shift, we created something called a personal care facilitator. And in essence, that's a member of staff that is allocated the position of being a personal care facilitator, and their sole duty, aside from what they normally would be doing, is to cater to the personal care needs of the service users within the service. And if that kind of means, you know, not going off the ward for that shift, then so be it. And through that, we saw a great reduction in, you know, any instances of people not being able to use, you know, it extended even more to bathrooms and toilet access, but also kind of female hygiene products and so on. And that was then replicated across a lot of other eating disorder services, not only within that organization, but also within ours now and across the pond in America, because sometimes you kind of think that it's an issue that only happens at your service, but it's actually more widespread. And through actually just listening to people and speaking to people, that's a policy that we was able to change. And then it had much far-reaching implications.
Now you've got some like 2 minutes left.
Thank you so much.
You're welcome.
So just to recap, really, the People's Council is a forum or a meeting, if you like, that takes place on a local level. Normally, it happens on a monthly basis within a hospital, and then it's replicated on a regional and a strategic level on a quarterly basis. And they're all kind of linking together, and they link in with other meetings on those levels. So, for example, on a kind of regional level, you'd have the regional people's councils, linking in with regional clinical governance, regional positive and safe care, and so on. And again, on a strategic level, they're kind of linking with the board meetings, nursing board, the executive management board, and so on. So it's a structure that we're kind of very proud of, and something that's been replicated across the sector now. And we definitely are quite proud of it, and would like to continue to seeing it rolled out. And what I'm hoping to do is to send over some materials to Paul, just for wider dissemination, and hopefully you guys can maybe just have a look at it and send over any suggestions, or if you'd like to take any suggestions yourself, you're more than welcome to.
Yeah, thank you for this offer. And I would like to suggest that those who are interested in all the material that Ralph has, put it on in the chat, please. And David, if you would be so kind to then put it down, then we can send the material by you through Paul to the attendees. Yes.
Thank you so much.
Thank you. I would like to thank you both for the really nice presentation, the beautiful video, and your explanation, the way it works in the UK. And in some parts, I'm a bit jealous. But I can also say it's inspiring how it works, and I'm looking forward to your keynote lecture in 2022. For the audience, we also need your help, because now the youth panel has only a couple of attendees. And if you know any youngsters from your country who would like to participate, please let it know. And I asked Paul to put down the mail addresses of himself and of Inge in the chat. So jot it down, and please send your suggestions to Paul, and then it will go along with the other expert by experience. Thank you once again. I would like to introduce, but first one question, because to you two, to put it in the chat, because we've got 2 rounds of question and answers to Tonia. The first one is 5 minutes, and the other ones is a bit longer. If you have, during the first part of the interview, a question you would like to ask, please put it in the chat. David and I are trying to combine the questions that are asked through chat. And once again, please pull down the menu if you see 2 to all panelists and attendees. Because if you only put down all panelists, then only 5 people can see it. And otherwise everybody can see it. Now, the first part of the interview, I'm really happy to introduce to you Ed Hiltman. He's Chief Scientific Advisor at the Dutch Expertise Center Forensic Psychiatry, and he will interview Tonia Nichols, and she is a professor at the Department of Psychiatry at the University of British Columbia. She's also an adjunct professor of psychology at the Simon Fraser University and distinguished scientist, British Columbia Mental Health and Substance Use Services. And the interview will be about patient-centered care and working from a protective factor approach. Go ahead, Ed and Tonia.
Hi, welcome to the interview with Tonia. Tonia, could you please put on your camera? Yes, very well. So like I said, we will talk about trauma-informed practice and patient-centered care. And so why are we interviewing Tonia? Tonia has been leading the development of the model of care for 2 hospitals in the Vancouver area. In these centers, patient-centered care and trauma-informed practice were implemented in recent years. So in the first part of this interview, we are going to talk about trauma-informed practice and patient-centered care, what it is, and also we'll basically start with what is trauma. And in the second part, we will talk about the experiences with the implementation of these models. Of course, that's important. Because we can find out all kinds of models, but implementation is here the most important thing. So, Tonia, to begin with, could you explain the necessity for these changes in your hospitals?
I think like any agency, we struggled with challenges around seclusion issues, and we're always looking to improve patient satisfaction outcomes from surveys, for instance. But let me just for one moment take a step back. I wanted to thank the conference organizers, Case, and yourself, Ed, for the invitation, and thank you to everyone for taking time out of their evening to join us. So I think we all need to work on improving care, thinking about the comments from Raf and Paul, for instance, from a patient-centered perspective. So we do regular annual interviews or surveys with our patients, and we always hear feedback around food. Often the food is rated really well, but programming needs and improvements. And so what we did was we brought in 3 international experts to do an external review. That was James Ogloff from Australia. So we had a lawyer and a psychologist trained there. Harry Kennedy is a psychiatrist. He came from Dublin, Ireland. And we had Michael Doyle, who came from Manchester in the UK. And so we've got this really nice, very representative group in terms of disciplines, but also in terms of geographic representation. And so they came and gave an external review looking at all aspects of our service. And my understanding is they've done this at a couple of sites across Canada, CAMH, and I think even presently during COVID, they've done a remote review, much like this conference, with the Nova Scotia Hospital. And one of the primary recommendations from that team, and it's sort of covered in this top piece here, was the need to do a patient needs assessment. So I think we all endeavor to engage in evidence-based practice, looking at guidelines like NICE or the American Psychiatric Association, the American Psychological Association, the European Forensic, the Royal College experts. But the advantage of a patient needs assessment is that it will inform you about the needs that are very specific to your patient population. Because I think as much as we all share a lot of the same challenges, there are certainly some differences culturally, for instance. And so we thought that was a very helpful recommendation. And so we did embark on one. I wanted to share this because I knew you were going to ask about the model of care. And essentially on the outside, I know our focus today is around trauma-informed practice. And we've heard from the people with lived experience, the young group, about the importance of person-centered services. And I think all of these things are sort of intermingled and inform all aspects of services that we should be delivering. But I thought this might be helpful to provide a context. So the work on this began, you mentioned there was 2 settings. We opened a new facility for people with substance use and mental health problems about 10 years ago. And that model evolved there. And then our agency, BC Mental Health and Substance Use Services, is responsible for all healthcare services in corrections, all tertiary or quaternary services for adolescents and adults. So that includes our forensic service and our civil psychiatric services. So we've embedded this approach across all of our agencies. Just to give you a little bit of a sense of what we did in the patient needs assessment, we wanted to look, as I said, at every aspect of the delivery of care. I'm going to focus today, as you've asked me to, thinking about, well, what was the findings or the outcomes around adverse childhood experiences and lifetime victimization and trauma issues. But I think a patient needs assessment is a really nice place for an agency that's trying to implement this kind of patient-centered care to begin, because what we do is we hear from the patients and the staff as well as family members, which would be a really good component to add in about every aspect of the care that we're providing. And I really liked the comment from Paul, I believe, about the finish approach, where we have people go in, maybe people who've been through the service, and doing an evaluation in that way would be a nice complement as well. What we did,
could you say something? You looked at the adverse childhood experiences, the victimization in your population and your practice. Could you say something about it?
It was one of the primary findings. So what we did was we embedded the quantitative findings from the patient needs assessment, where we looked at the files and coded measures and had a 100-page coding protocol. We wanted to supplement that with conversations with our staff and our patients. And what you can see here is some of the quantitative data. So we found that about nearly 40% of our patients have more than 4 types of adverse childhood experiences. And a particularly traumatic event for a young person is to be removed from the caregivers. So 1 in 4 had been in foster care. And then we took that quantitative data and we synthesized it with what we called patient journey mapping and staff journey mapping. So we had artists come in, and so you can see some of the comments from the patients here. It's important that staff show compassion. Sometimes new graduates can be textbook. Patients told us about feeling like the units were loud and chaotic and how this could create anger. I think that reflects on the video that we saw, how the neurobiological implications of trauma can affect people. And then we heard from staff about the importance of helping patients to get oriented to the institution. So across those 3 different data sources, we did what we called a top 10 list to try to share the findings with our staff and our patients. So we did town halls, but this was one of those top 3 in terms of how often, what was the prevalence rate, and what was the severity of symptoms that followed. So not only was it common for people to have these experiences, there was a lot of diversity in the types of experiences, and they're quite severe. So when you talk to the general population, we often have potentially traumatic events, but not necessarily involving caregivers.
But what do we mean when we say someone has been traumatized?
So historically, people probably remember, some of us who are a little older, we used to think about trauma as being a normal reaction to an abnormal event. But I think what we're going to see in the video that you're sharing today, and what I wanted to communicate, is that research is increasingly, especially in the 90s, we've started to discover this, and in the last couple of decades, is that trauma is actually a normal reaction to extreme stress that overwhelms that individual's capacity to cope. So I think there's a couple of important things here to note. First of all, it can come from a variety of different types of events. So it could be war zones, it could be an accident. So trauma can happen in those kinds of situations, but it's quite variable in terms of what the impact is on the individual. I also think it's important to think about the fact that part of the definition is that it overwhelms the capacity to cope. So there's a lot of individual variability. So simply knowing that something happened to someone, we don't want to, I think, over-intervene. Very consistent with the risk needs responsivity model, it translates to this kind of service as well, that we want people to have as much autonomy as possible. We don't want to over-intervene with people. Well-meaning caregivers can actually cause harm. We know that. And so just assuming is not appropriate. We want to make sure we understand the person's individual experience. When we look at what's called potentially traumatic events, many people in the general population have experienced these things. So some research seems to suggest it's, within the range of 50 to 60%, regardless of whether we talk to adolescents or adults. And these data are North American. We did try to find some European information. It's from population-wide information though.
Well, you mentioned that it's important to recognize that although most of us are exposed to potentially traumatic events, the PTEs, that doesn't necessarily equate with trauma. So what's the difference?
So it depends on several things. I think one way of thinking about this, because it can be really stressful for staff to try to imagine, what do we mean when we say trauma-informed practice, and how do we embed this? And I'm not a psychologist, or I'm not a trauma expert, even if I am a psychologist. So thinking about the fact that all of our patients potentially have experienced trauma, we simply embed universal practices. And then imagining that of that group of people, some people will have some trauma symptoms, and then there will be a small proportion in the middle who might actually have full-blown post-traumatic stress disorder. And all of our staff, we can all do something to help minimize this. So minimizing triggers upon admission to the institutions or the care facility, to helping to de-escalate situations, avoiding the use of restrictive interventions like seclusion and other measures, thinking about the language that we use, all sorts of things. What we need to be mindful of is that although these events are common in the general population, and this is a very well-respected study that sort of shifted the whole tide on thinking around this, is called the Adverse Childhood Experiences Study. It was done in the US in the 90s. And what they found is, yeah, these events are really common in the general population. And I think that's important from a population healthcare perspective. But we are all forensic experts, and we're dealing with people at the deep end of the continuum of needs and services. So although we know in the general population, abuse, even direct abuse, emotional, physical, and sexual abuse is shockingly common, neglect is not that rare, and there's a lot of family dysfunction. So when we think about the fact that 1 in 10 people has experienced some form of emotional abuse, that seems really, really high. But we also need to be mindful that within our populations, the types of events, the prevalence of events, the incidence of events are quite unique. So I just wanted to share with you what you see here is a comparison of that general population data, and across the bottom is the number of different types of adversities in childhood that justice-involved adolescents have experienced. So there's the complete opposite trend. In justice-involved adolescents, very few people have 0 events. And many people within the general population haven't had any of these things. So they haven't had a divorce in the family. They didn't live with a caregiver who had a mental illness. No one who was a caregiver was incarcerated. They didn't suffer any neglect or abuse. What's really important is to think about the fact that many of the people that we care for, many of our clients, have experienced many of these different types of things repeatedly. Sorry, Ed, go ahead.
No, this is all very interesting, but I had in a previous life, some time ago, I had a training. I was trained as social worker in graduate school, but I really don't remember learning anything about ACEs, potentially traumatic events, trauma-informed practice, or whatever. I don't even remember the word trauma was mentioned.
Yeah, it is shocking. Like I said, the Adverse Childhood Experiences study came out in the 90s, and it was 2 physicians who were working separately across the states. And the doctor was actually doing treatment for people with obesity in a relatively high income group because they were working. They were employed and had insurance. And it was generally white middle-class individuals. And so even in the 90s, our GPs weren't aware of this. So when he was doing these interviews, he actually talks publicly in the media about how he misspoke while he was doing an interview. And he was feeling frustrated because a lot of their patients were backsliding. So it was an obesity clinic. Many people would take off weight and then they would start to put the weight back on. And he was doing an interview and said to the woman accidentally, "How much did you weigh at the time of your first sexual encounter?" And she said 40 pounds. And he realized he'd misspoken. And so he repeated the question and she answered consistently and started to cry and said, "I was 4 years old and it involved, I don't recall if it was her father or stepfather." And then that happened again a couple of weeks. And I think very much like you, Felidi and Anda talk about this. I myself have had this experience going through a really reputable graduate education, and I work with a GP at our hospital. And again, she and I have come at this from different perspectives. We started surveying our patients and she started trying to educate our staff. It hasn't been, I don't think, a strongly embedded component of our education. And when you guys asked me to do this interview today, I was doing some searching, and one of the things that I came across was education for family physicians about how to do trauma-informed physical examinations. So it's really nice to see that it's making its way into the education materials, but I think it's still something that we need to work on. And so I think there's a lot of work to do, but I think the data is actually pretty clear that this is the way we should be moving. And as much as it is common in the general population, and that's really important, as the video will demonstrate, and I wanted to show you what you see is a cumulative burden.
Tonia, and Ed,
Yes.
we've got 4 minutes left.
Yes, thank you.
Yeah, thank you.
Thank you, Grace. What you can see is a cumulative burden. So the more, what I know, this is extremely busy, but I did that purposely because the more types of events, the bar graph goes from 0 to 4 or more. And what you can see is across a diverse range of different physical health problems, mental health problems, family adjustment issues. So you see here, smoking, obesity, injecting drug use, financial problems, alcoholism, sexually transmitted diseases, hallucinations, having over 50 partners, teen pregnancy. This is data from the general population, and we're looking from 0 to more to 4, and you get this very consistent gradient increase across all these different types of outcomes.
So
what I was showing you is that even in, that's dramatic, but look at the difference for patients or clients that we are caring for, that the number of individuals.
That's something I wanted to ask you. You spoke about the general populations. Our clients have these traumatic events also. So what are the effects, the implications of these kinds of effects for our clients in forensic? In a recent review, like you said, from Malvado, published this year, they found that 87% of justice-involved juveniles have had at least one ACE.
Yeah, that's exactly the challenge. So it's very rare, I think, in many of our client populations to see that somebody will not have had any of these events. So that you get that graded increase, that the more types of events they've had. So the prevalence rate is high, then the incident rate is also high. The other thing that I think we need to be mindful of is that when we think about the impact of trauma, you can think about the 3 E's as one approach: the type of event, the person's experience of the event, and then the context or the environment in which it happens. And all of those things then determine what the effect is. So we talked about potentially traumatic events versus trauma. So our patients are more likely to have events, and the types of events that they encounter, like I said, it's more likely to be direct abuse than it is just to have been a motor vehicle accident. And not just, I shouldn't say just, I don't want to diminish the importance of other traumatic events, but when events involve a caregiver, a trusted person, or a direct assault on the person's bodily integrity, it may result in fear, the inability to escape. That's the perception. And then if a person doesn't feel supported or believed, or the event continues to go on, perhaps there's a caregiver in the home and the other caregiver is not coming to the young person's rescue, those 3 E's help to dictate what it is that the long-term effect is. And that's why our clients are much more likely to have the resulting risk-taking behavior, maladaptive coping strategies, inability to ask for help, a difficulty developing a therapeutic relationship because they've been taught not to trust people in positions of authority. And then suddenly we say, well, I'm here to help you. We need to trust one another. And of course, it's difficult for them, right? So it's the case that our clients are much more likely to have repetitive events. They're much more likely to be the direct victims of events than to simply have been a witness, for instance. Many people have experienced these things at a young age, which is a particularly problematic time period for them. And then, as I said, it's often in terms of what's the nature of the relationship with the person, and that can magnify the effects.
Okay, thank you, Tony and Ed. It was Ed's brilliant interview, but we also got a couple of questions from our attendees. The first one I would like to ask to you, Tonya, is a question from somebody from the Netherlands. And the question is, do you feel like efforts should focus on preventions of adverse childhood experiences happening, or on how to adequately handle life with these adverse childhood experiences? For example, resilience.
For example, sorry?
Resilience.
Resilience.
That was
yeah.
But the first part was prevention, or should we focus on how adequately handle life?
I would love to say prevention, but I think realistically, we have a responsibility to do both. I think prevention, some of the comments that the young persons group made, I think really resonated with me, because I was thinking about the comments that I'm going to be bringing up and the importance of, I call it going upstream, right? If we could educate families, even in the schools, right? We're starting to make that shift, I think, a little bit in Canada and North America to some extent, talking about budgeting and putting together a resume for a job, but we don't spend a lot of time talking about healthy families. And I think if new parents and caregivers and young people had just a little bit of a sense of the importance of being responsive to infants even, and thinking about the implications of this for attachment, for instance, right? We know that attachment becomes often a lifelong paradigm approach to relationships. And so, yeah, I agree. Prevention is absolutely vital. And I think it reflects on politics, at least in North America, because people serve 4-year terms. There isn't enough time to implement these changes and to be able to see the long-term benefits, but we do see it, and hopefully Ed and I will have some time to talk about that, but trauma-informed interventions are cost-effective, and I think prevention would be even much more so. There are some services, I think, that are getting put in place we have a place called Covenant House. We have Big Sisters and Big Brothers programs where you partner young people who don't maybe have a person of the same sex or gender in the household to provide mentorship. But there's so much more that we could be doing. And I think education about the parenting is vital. And then the other piece you asked about is resiliency. And I think that is such an important point, and especially to share with our patients, thinking about patient-centered care and family engagement, to help people to understand there is hope. You are not your ACEs score, right? The brain.
Is this also in the next session 2? Are you talking more about patient-centered care in combination with trauma-informed practice? There's also a question about that. What a wonderful approach. I was wondering, can Professor Nichols give an example of how trauma-informed practice translates to patient-centered care? Will you focus on that later on, or it's better to answer this question now?
I think it would be good to answer that one, because we don't have a lot of time, and we wanted to talk a lot about implementation, which let's touch on that.
Yes.
I think if we think about the impact of trauma, one of the biggest things is a sense of distrust and the need to support autonomy, and a sense that what I need or what I want, my safety, my well-being is important. And so in patient-centered care, those things go hand in hand, right? We want the patient to be collaborating, not that we provide the care plan and the patient is just a recipient. I think all of these things I said, we need to knit them together, and they're so intermingled. But to me, patient-centered care is about making sure that the patient and the families, as appropriate, are integral to everything that we do. So planning the environment, thinking about what helps that person to feel safe. So asking our patients as they come into the institution, what works well for you if you're feeling upset, and what might actually be triggering for you. So I think patient-centered care and trauma-informed practice share a lot of the same values, and a lot of the same approaches are mutually supportive.
Thank you very much. Also to add, for this first part of the interview, there is 1 or 2 questions left, but I will see if it fits the second part. So to all the attendants, we now have a break, but there's also a beautiful video. And I would like to ask Lodewijk if it's possible to run this video during the break, so you can also have a break and see the video. Enjoy your break, and we see each other again at 8:10 Netherlands time, CET. And then we start directly with Antonia. So we'll see each other afterwards at question and answer session. Have a nice break.
What does your parents' divorce have to do with your risk for heart disease? If your mother had a drinking problem when you were growing up, are you more likely to suffer from depression as an adult? Here's what you should know about ACEs. ACEs stand for Adverse Childhood Experiences, extremely stressful events that can happen to a child growing up. Some experiences are so stressful that they can alter brain development, as well as the immune system, increasing the risk of lifelong health and social problems in adulthood. The term comes from the Adverse Childhood Experiences Study, landmark research that shed new light on the root cause of everything from stroke and liver disease to substance abuse and mental illness. In the late 1990s, an epidemiologist from the Centers for Disease Control and a preventive medicine doctor at Kaiser Permanente set out to understand the association between childhood experience and lifelong health. They asked over 17,000 people in the Kaiser Health Plan in San Diego about their health history, as well as difficult questions about their experiences growing up. Anda and Felitti tallied up 10 different kinds of adversity in this largely middle-class and college-educated population. They were stunned to see how common ACEs were. 21% of all respondents were sexually abused as children. 19% grew up with someone who suffered mental illness. 28% had been physically abused. And 2 out of 3 respondents had experienced at least one ACE. The researchers next looked at how someone's ACE score, or the number of adversities they experienced, related to a wide array of serious health and social problems. They saw that the more ACEs someone had, the greater their risk for poor outcomes compared with someone with no ACEs. Someone with an ACE score of 4 had twice the risk of heart disease and cancer. Someone with an ACE score of 5 had an 8 times greater chance of being an alcoholic. And those with an ACE score of 6 or more, on average, died 20 years earlier. With every major problem they looked at in the ACE study, the risk went up for each additional adverse experience in childhood. As Dr. Robert Anda says, what's predictable is preventable. It's important to remember that ACEs are not destiny. ACEs are a tool for understanding the health of a population as a whole. For individuals, an ACE score can be a tool for understanding their own risk for health and social problems and empower them to make changes for themselves and their children. ACEs tend to get passed down from generation to generation and are common across all income levels, races, and cultures. But increasingly, people of all different professions and backgrounds are coming together to discuss how ACEs affect their communities. They're finding new ways to treat and prevent ACEs. Many doctors are starting to screen their patients for ACEs as part of their medical history. More schools are becoming trauma-informed, considering the source of problem behavior when disciplining their students, instead of immediately suspending or expelling them. To learn more about interrupting the cycle of adversity and improving health and well-being for the next generation, please visit kpjrfilms.co. What does your parents' divorce have to do with your risk for heart disease? If your mother had a drinking problem when you were growing up, are you more likely to suffer from depression as an adult? Here's what you should know about ACEs. ACEs stand for Adverse Childhood Experiences, extremely stressful events that can happen to a child growing up. Some experiences are so stressful that they can alter brain development, as well as the immune system, increasing the risk of lifelong health and social problems in adulthood. The term comes from the Adverse Childhood Experiences Study, landmark research that shed new light on the root cause of everything from stroke and liver disease to substance abuse and mental illness. In the late 1990s, an epidemiologist from the Centers for Disease Control and a preventive medicine doctor at Kaiser Permanente set out to understand the association between childhood experience and lifelong health. They asked over 17,000 people in the Kaiser Health Plan in San Diego about their health history, as well as difficult questions about their experiences growing up. Anda and Felitti tallied up 10 different kinds of adversity in this largely middle-class and college-educated population. They were stunned to see how common ACEs were. 21% of all respondents were sexually abused as children. 19% grew up with someone who suffered mental illness. 28% had been physically abused. And 2 out of 3 respondents had experienced at least one ACE. The researchers next looked at how someone's ACE score, or the number of adversities they experienced, related to a wide array of serious health and social problems. They saw that the more ACEs someone had, the greater their risk for poor outcomes compared with someone with no ACEs. Someone with an ACE score of 4 had twice the risk of heart disease and cancer. Someone with an ACE score of 5 had an 8 times greater chance of being an alcoholic. And those with an ACE score of 6 or more, on average, died 20 years earlier. With every major problem they looked at in the ACE study, the risk went up for each additional adverse experience in childhood. As Dr. Robert Anda says, what's predictable is preventable. It's important to remember that ACEs are not destiny. ACEs are a tool for understanding the health of a population as a whole. For individuals, an ACE score can be a tool for understanding their own risk for health and social problems and empower them to make changes for themselves and their children. ACEs tend to get passed down from generation to generation and are common across all income levels, races, and cultures. But increasingly, people of all different professions and backgrounds are coming together to discuss how ACEs affect their communities. They're finding new ways to treat and prevent ACEs. Many doctors are starting to screen their patients for ACEs as part of their medical history. More schools are becoming trauma-informed, considering the source of problem behavior when disciplining their students, instead of immediately suspending or expelling them. To learn more about interrupting the cycle of adversity and improving health and well-being for the next generation, please visit kpjrfilms.co.
Hello, so we continue with the second part of the interview. So Tonia, there is a lot of knowledge, but the problem I think is that, and the challenge is to use this knowledge in practice, so in implementation. How can we implement this and use this knowledge in practice? Or in other words, how can a service provider become trauma informed?
I don't think there's any one answer is the first issue. I think despite the fact that this is relatively new knowledge, there are some good supports that are available. People like Bloom, Fallon and Harris have produced some really useful documents, and I will make that available to the conference organizers to share. But I think it's a stepwise approach. I think it's about everything that we do, essentially. And I can imagine that agencies sometimes feel like this is overwhelming, or even individual clinicians. And so it's important to be mindful. We can start small and we can build.
What do you mean trauma-informed practice is about everything we do?
So
do you mean that everyone who works in a service provider, that could be a hospital or an open sector, has to be trained?
Yeah, that's also a really good point. So if we think about that diagram where I showed that we need to endorse universal precautions like hand washing, imagining that virtually everybody that we encounter, all of our clients perhaps have had some trauma. And so everything that we do, from the person who answers the phone and responds to caregiver questions, to our cleaning staff, to the person who works in the kitchen, to security officers, if you have those on site, all the way to the social workers, nurses, psychologists, and psychiatrists, all of us need to be aware and we need to be mindful, but we don't all need to have that trauma specific intervention expertise. So there's a couple of things here. I think, like I said, it's about everything that an organization does. And this is probably like a generational approach that is going to require change. From how we advertise for our staff to the people that we hire and the orientation and continuing education that we provide for them. So our agency has been on this road probably for 5 to 10 years, and we now embed language around looking for people who support patient-centered care, people who have expertise or at least are comfortable adopting this perspective.
I think maybe in general, there's an idea that trauma-informed care and patient-centered care are about treatment. But how you put it, it's not about treatment. It's about an attitude.
That's a great way of putting it. I think, like I said, it's about everything that we do. It's about the way we design our physical settings, whether we have natural lighting, whether we have plants, whether we provide access to food when people visit. It's how our leaders interact with our own staff, for instance. It's not just about how our staff interact with patients, about how we treat one another, for instance. Sorry, can you say that again? And I lost my train of thought.
No. I said it's the tip and the patient-centered care. Normally you think it's about treatment, but how you put it, it's not about treatment. It's about an attitude of everyone who works with patients. But there's also another thing, I think, behind. The numbers you showed before about the general population, that would mean that not only patients have traumas, but also staff. And how do you handle that?
Yeah, it's actually a really important point. And like I said, so it impacts on our attachment styles, which affects how we interact with our colleagues. Anxious attachment can result in people being very fearful in the workplace, feeling like other staff are talking about them. People who have fearful attachment styles might have difficulty in their therapeutic relationships with the patients. So how do we handle that? I think it's evolving, but basically my understanding of the recommendations and guidelines and research is the way we interact with one another, the way our leadership interact with our managers and our managers interact with our staff. All that we do needs to be trauma informed. So it's respectful. It's about ensuring that you maybe have on-site exercise equipment, space for staff to get away from one another and to get away from patients, but also maybe to have opportunity to support one another. We've done things that are sort of more client oriented and service specific, like having handovers and huddles, so that when one nursing group is leaving, say at 3 o'clock in the afternoon or 7 in the evening, the oncoming group spend some time together to find out what's the temperature on the unit. How's Mr. Jones doing today? He had a really difficult day yesterday. He was expecting an absolute discharge, or he was anticipating his mother was going to visit and was very disappointed when she wasn't able to make it. And just that touching base with one another. I think a lot of that is about patients or clients and where things are at on the unit, but I think it's also a good opportunity for staff to remain connected. I don't work shift work, but I can imagine it would be difficult. At an organizational level, we've started to do things like town halls. So when I talked about the patient needs assessment, we did presentations all day long at various times, trying to allow people to come before their shift, during their shift, after their shift, people who had different, women who work in the morning because they want to be home with their children at night, or men who have to do childcare pickup, and then people who work in the evening, trying to be more flexible and supportive, having healthcare provisions for our staff as well as for one another.
But as you explain it, that sounds like a considerable undertaking for a service provider or hospital. You mentioned you can go from small to big or broader trauma-informed care implementations, but how would that look like? How do you start small? How do you advance afterwards?
So I think some small things that you can do. So for instance, we all, I think many of us at least, struggle with a small proportion of patients who are perhaps particularly difficult. We'll have a small group of individuals for whom they're repeatedly self-harming or repeatedly aggressive on the unit. So one of the things that we can do is work with an individual patient who's creating a lot of stress for other patients, for themselves, and for staff. So you can start to employ trauma-informed practice within one individual care plan. And one really pragmatic and relatively inexpensive and very useful approach that we've found in the literature and that we've been employing in some of our centers is what's called a comfort kit and a comfort plan. So when the person comes into hospital or joins the care team in whatever way, I think having a conversation about what works for them, what helps them to calm down. I talked a little bit about this before the break, but for some individual, sorry.
Yes, in the preparation we had to this interview, you showed the form you use at intake, where you ask patients what works for you and what triggers you.
Yeah. So when we do intake assessments, I think it's very helpful. And I know that sometimes people are concerned that talking to patients about trauma can be triggering. But I think that's a myth, much like the old myth around suicide, that if we ask people about suicide, that they're more likely to become suicidal. What you hear from patients, in fact, is that they feel validated and that the staff are sincerely interested in helping them to have the most safe and most helpful stay with us that they can. So asking individuals about what triggers them. So for one individual, it could be a scent. It could be that some nurse on the unit wears a cologne that maybe an abusive caregiver has worn in the past. It could be when you come into my room and you close the door before we have a conversation, that reminds me of an adverse event in my background. For me, when I'm distressed, I find it really helpful to engage with a friend or a family member. And a lot of our patients talk about how helpful it is for them to talk to nursing staff and have somebody who's responsive. So I think being really attuned to the individuals on the unit can be really helpful. But on the other hand, there's a lot of people who just want to be alone. And so we need to be mindful, again, thinking about patient-centered care, that what works for me, you and I both like to run, Ed. For somebody else, that might be pure torture. That would be the last thing they would want to do when they're feeling distressed. And so on the other hand, for them, maybe listening to loud rock music or having a warm bath. For me, having a friendly touch or a hug is very comforting. For somebody who's been assaulted, that might be a very inappropriate, it's well-meaning, but we need to be really mindful from a patient-centered perspective. We need to know what works for that individual, not to make assumptions.
So you ask when patients or clients come into your center, you ask them all these kinds of things. But you also explain that patients does not necessarily trust you. They are in a new environment, the new people who they don't know, who they don't trust, and they are going to tell you all these kind of things.
Well, I have to be honest. I've worked in correctional settings where we do intake assessments in very short periods of time. I think by and large, like I said, people find it reassuring that you are truly interested in them as an individual.
Mm-hmm.
They find it validating. This might be the first time that somebody has acknowledged that maybe their behavior is a reflection of the negative experiences that have happened to them. By and large, I very, very rarely, in my personal experience, have encountered people who are entirely reluctant to answer these kinds of questions. That being said, we're also dealing with individuals who might be suffering from very acute symptoms. So they could be paranoid, or like you said, they may not engage with me for whatever reason. There's nothing wrong with putting off that conversation. Again, we need to focus on individual assessment and patient-centered care. If it's not the right time for that person because they're acutely psychotic, or because for some reason, maybe they've just had a really distressing day, moving from some rural setting, being transported by ambulance to us, they might just want to sleep. And so there's nothing wrong with putting that conversation off. And I also think we need to be mindful, especially with young people, they may not know what these are yet.
Mm-hmm.
Right?
At Antonia, 5 minutes left.
Thank you, Grace.
Welcome.
So I think it's helpful to, when it's appropriate and there's a healthy relationship, I think it's really useful to talk to family members. They might have a sense of what sets people off, but it can be a part of the treatment plan to say, okay, that makes perfect sense that you're not sure yet, but let's work on developing a diary or keeping a record of what you have found. You know, when somebody said to me on the unit, you're a goofball, in North America, that term in correctional settings is very inappropriate. Or it could be that when somebody calls you sweetie, that sets off alarm bells because that was a term that an abuser used. Mm-hmm. So it might take time for the person to start to recognize these things. And I think that can be a really valuable process. It doesn't have to happen right at the time of admission. I don't mean to suggest that.
No, but I agree. It can be part of the treatment that someone learns the triggers.
And also what helps them to
What helps them to overcome that.
Yes. Yeah. And I think that's a big part of our role around adverse childhood experiences, is helping people to develop healthy coping strategies rather than using alcohol, rather than punching somebody, trying to find alternative approaches. And we've co-presented with young individuals who've been through our services. And one of the women talked about how she's now in a healthy romantic relationship, and she has a list on her fridge of what works for her: taking a warm bath, reading a book, phoning a friend, baking, knitting. And so when she's feeling distressed, her partner will just quietly point at the fridge, or she will acknowledge it herself, and she goes and looks for something. And so in the hospital, what I was sort of getting towards, one relatively inexpensive, very individualized thing that we do is coming up with comfort kits. So you can have that kind of a list of approaches that works for the individual. And you might also have other things in a box that the person adds to over time. So it could be a CD of their favorite band. It could be lotions and scents that help the person, a yoga mat. That's a little big for a box, but you know what I mean?
Yeah,
A list of yoga poses maybe. But what's nice about that is it can go from the person, it's theirs, and it can go with them from unit to unit, and they can take it home. And it's a really pragmatic approach and something they can continually add to.
Okay, so this all sounds very interesting and nice, but in the justice context, there are also people who prefer a more repressive approach. How do you get it implemented with these people? They might see it. Oh, that's very soft.
Yeah, it's challenging. I think implementation is one of the places where our field has sometimes fell down. We've got great risk assessment measures, and it takes a long time to get them implemented. And then implementation, you see drift over time. And that certainly is the case with this. And I think in much the same way, we've seen that from the time that we have this knowledge, it takes about 17 years on average for best practices to go from inception in research and clear evidence that they're
so you're saying that if we start today with the implementation of patient-centered care and trauma-informed practice, we end up with the implementation in 17 years.
No.
Okay.
No, sorry. Let me be clear. I mean, we've known since the mid-90s that this is important, and it's 2021. It takes a long time for these things to happen. What I meant to say is that it takes a long time for knowledge to reach direct care.
Okay.
And we have a lot of leadership here, and now we need to take this information and be champions on the unit and share it with care providers. Case, do I have just a moment to address the soft versus?
Yes.
Yeah, I think that's a challenge in correctional settings. It's perhaps hopefully a little bit less in forensic context because we are supposed to be mental health services, but nonetheless, a lot of our staff do struggle with the notion that our patients or our clients are offenders. And I think what we can do is come at it from many different directions. First of all, the research suggests it works, and that means a lot of things. It's cost effective. It reduces staff assaults on the unit, so assaults by patients on staff on the unit. So it's about individual clinician safety. If you have staff members who are really embracing the value of fostering the well-being and recovery and community reintegration of your patients, it helps patients to develop better coping strategies, and return to the community more successfully. So reducing substance use problems, alcohol and drugs. There's good evidence that it helps to reduce criminal justice involvement.
But
So
you mentioned all risk factors basically, but I think but also the more attention for the protective factors in this approach would be much more important. Well, people know what they can do, they know their deficits,
yeah.
but they don't know their strengths.
Absolutely. But I think that's part of that healthy coping strategy, right? Embedding yourself with pro-social others and trying to remove yourself from antisocial networks. So pro-social supports, healthy coping strategies, seeking help when you need it, whether that's a professional, whether it's the nurse on the unit, whether it's a friend. Acknowledging that your capacity to play the piano or play the guitar, or that you have lived experience, like we heard from the introductory comments today, and you can come back to the field and you can support other people in their journey towards recovery. I absolutely agree with you. I think that's a really valuable aspect of this work, is that it helps to build people up as well as reducing deficits and vulnerability.
Okay, thank you. I think we are now into the time of the questions and answers. So I'll give it over to Gijs.
Yes, thank
Thank
you
you very
all.
much, Tonia.
Thank you,
Tonia.
Pleasure.
Yeah, I've got a couple of questions. First, two reactions from the Netherlands really applaud your approach. I just quote them. I would like to inform Professor Nichols on the attitude and leadership style of the long-term forensic psychiatric care, where several of the attitudes and forms she mentioned are applied to a very traumatized group. So they're really happy with your interview. And another reaction is that the methods early warning signs by friend Frans Fluttert is often used in the Netherlands in forensic settings. So there are people following you, and also countries who are in the same way dealing with the topic as you are, which I think is a great to hear. I've got one question. It's a long quote, but I will quote it. Kelly Irving and Del Pierre note that adverse childhood experiences are useful for describing the need to act upon complex social environments to prevent health inequalities at the population level, but should not be used to diagnose individual level vulnerabilities. This is for the same reason you noted that adverse childhood experiences are not deterministic. However, the video in the break did seem to suggest to do the latter. What are your thoughts on what should be done with knowledge of someone's adverse childhood experiences on an individual level?
Yeah, I think that's a really important point. I'm happy to say that the Adverse Childhood Experiences team is very aware of this. And if you visit some of their website, for instance, they've started to recognize that I think the measure is almost starting to be used inappropriately to some extent. It's that caregiver desire to do good work, but sometimes taking it a little bit too far. So I think if I were to imagine the measure, it's a good starting point. It's sort of like perhaps a screening tool at best, but even then, as I try to articulate with respect to our patients, it doesn't ask about a great variety of different types of adversity and victimization, right? It's only focused on childhood primarily. And the early measure talked about intimate partner violence by men towards women. It didn't ask about reciprocal abuse, for instance. And there's a whole host of other forms of trauma that people experience. So it's missing items, and they acknowledge that. The other thing that I think the panelists or the attendees speak to is, again, it doesn't ask about the nature of the relationship or the severity of the event. So simply because I've had a motor vehicle accident doesn't mean that I'm going to develop trauma symptoms. Even if I experienced an event of childhood sexual abuse, there's a strong meta-analysis. It's getting quite dated now because that's not my area of expertise. But at the time, the conclusion was many people make a full recovery and don't have severe adverse outcomes following restricted childhood sexual abuse, particularly if they are in a healthy environment. And I think Ed's point about protective factors is so important. And the video did speak to that. We are so much more than just our ACE score. I think the video is a little dated now. So if it misconstrues that, I'm happy to say, like I said, if you visit some of their more recent materials, they really do acknowledge that it's not diagnostic, and it's it's intended at a population level.
Okay, thank you. I've got another question, and that is, how do you deal with traumatic experiences in your staff if something bad happens in your hospital? So how about the staff and their traumatic experiences?
I don't feel like I have a ton of expertise on that directly to speak to that. I think, as I said, my understanding is that this is about everything that we do. It's not just about caregiver and client. It's about caregiver and caregiver, colleagues supporting one another and communicating in respectful, collaborative ways. It's about the way that our leadership care for our staff. And I think we've seen a lot of this during COVID. The importance, so when my laptop fires up, there's a phone number that says if you are experiencing any distress, you have employee coverage, and this is the phone number you can call 24/7 for support. So that's a high level piece. I think being really mindful that when we come into the workplace, recognizing that we all bring our daily experiences and our personal contacts with us, and maybe checking in with one another. How are you doing today, Case? How was your weekend? And being supportive. And I think that's something that sometimes gets lost because we are all so focused on the timeliness and the client and our services, but it's important that we check in with one another. So trauma-informed practice is not just about how we interact with clients, it's about how we care for our staff as well.
I've got another question. I quote again, "I love your perspective on taking care of someone's needs and triggers in an informed way instead of assuming. However, what do you do when you can't accommodate for that? For instance, in the trigger list where being restrained and being isolated. But those things are sometimes unavoidable within forensic care." And I would like to stress sometimes, but that's a personal point of view.
Yeah, I think we all agree, and World Health Guidelines, many prestigious agencies have sort of determined restraint, seclusion should be used as rarely as possible, and if essential, for as short a duration as possible. We have seen in our work, and I'm also thinking about some of the work that people like Michael Daffern and James Ogloff did in the US, where we've implemented multitudes of different policies and procedures and checks and balances, and Daffern and their team published on a very similar stepwise approach. So thinking a lot about what we're talking about today, but applying it very specifically to seclusion reduction. And the conclusion that I saw in their publication is that despite that, on rare occasions with a small proportion of patients, it's very difficult to avoid. And I think, unfortunately, in our agency, that's sort of where we've landed as well. That being said, I think the question asks, what do we do then with that complex individual or that persistently challenging patient who has perhaps been in the side room for some period of time? And what you'll see sometimes is there's very rational, very appropriate fear on the part of staff and patients perhaps as well. And perhaps a little bit of nihilism and therapeutic nihilism, I mean, feeling like nothing works. So I'm really pleased to say that we have a small team at our hospital who has done some phenomenal work. It's our recreational therapists. And so they do some one-on-one interventions, and they're phenomenally creative. They will show up and they do, first of all, a recreational assessment. So I come to the window case and I say to you, what sort of things did you like to do? What are you interested in? And maybe you tell me that you used to like to watch gymnastics and you were particularly interested in the Olympics. And I know the Olympics, hopefully COVID safe, is coming up. And so I make a date with you and I reserve a television and I bring it, and you and I watch the gymnastics on the television together. And so it's a recreational assessment. It's trying to engage the person initially safely through the door. And I know that's not ideal, but it's a starting point. And then they will start to slowly bring the patient out. They might be in canal restraints, for instance, and they'll slowly bring them out on the unit. And that does a lot of things. First of all, I think it helps to instill hope in the patient. This isn't forever. There is potential here. And it demonstrates to the staff, hopefully, by and large, we have not had a very serious event. We have had on occasion a patient try to punch someone, but I don't think we've had anybody injured. We've got young, very spunky staff, and they know to stay a certain distance away initially. But they'll then maybe play cards on a unit. And I think what that does, so you've instilled hope in the patient, it can also help to instill hope in the staff if they see this person. And we have had some phenomenal successes where they have had patients who were in the side room for months, for very long durations, who are now successfully living on the units.
Well, I think you combine the question about optimization of staff and how to take care of patients in a very beautiful way in your last words. So I would like to suggest to have this as a last question and your last response. Once again, I would like Ed, if you could also join us again on video. Thank you both for this very nice, clear and easy to follow interview. So it must have cost also some preparation to do this together. So thank you so much. And for those who are attending, Tonya Nichols is also one of our keynote speakers at the 2022 conference, as is Raf Hamaisia. So you had the opportunity to also get to know them already a bit. And well, I would like to thank you for joining us. And I hope that you will all join us at the 2022 conference called Youngsters Position in Youth Forensic Psychiatry. Do we dare to change the rules? And if I look at how the information was this evening, I think we can do it together to change, that we dare to change the rules. I mean, I'm looking forward to it. I've got a feeling I'm forgetting something. Let me see. No, nobody is.
No, there are no questions.
Reminding me of anything.
May I thank the participants for spending their evening with us, and thank you very much for your attention.
Yes, thank you, Ed. And now I would like you a good evening, and once again, thanks to Tonya and Ed and the other speakers, Paul and Raf. And we will end with a small, short last video. But before that, I say good evening, and for those who are watching the song context, a lot of fun later on. Bye-bye.
Thank you.
But yes, the video will start.